Just a quick story. You all know about sponsors, right? The Gabrielle who owns Alpine Stars was watching me lecture 5 years ago. An A-Stars golf show. He came up and we need to get you a shirt. And he asked what size. So I figured I'd get a shirt in the mail. I got a sheet to take to a tailor. I don't wear tailor clothes, trust me. But because we're videoing and Gabrielle is very much involved in the entire industry, I figured I better wear the shirt. I want to thank you all for allowing me to be here. I went to the first seminar the coaches had down at Dallas, and then also the meeting down at Temecula Creek Inn. And so I'm very familiar with it. I do have to give you one set of kudos. Lindsay and Christy sent me a brief link to get into the medical side of the training course. I took the pre-test on concussion. I nailed that one. The cardiac test, I missed one, but I'm a bummed out. So, now, I teach young residents. They're getting a concussion talk in 3 weeks. They're getting the same pre-test you all do, okay? And you've heard about me already. And I work with the A-Stars Mobile Medical Unit. I live in Temecula, California. So between Temecula and Marietta, we have a lot of riders, not only motocross, but off-road riders, freestyle guys, BMXers, mountain bikers. It's an extremely active community. When I moved there, I had no clue in the world I was going to get into this, but it's worked out very well. Let's start with just the first part is a little dry, and I apologize for that. And I'm not going to read this to you, but the most important word up there, 2 words, complex pathophysiology. Right? It is not, it's a problem in the metabolism of the brain, not necessarily in what we call macroanatomy, such as a bleed or something like that. It's lower than micro. It's a physiological problem. And it can be caused by a lot of forces. In auto racing, the most common concussions are in drag racing. And it's the acceleration, not the deceleration. In moto, we get a little bit of everything. What is it? And I stole this from Doug Smith at the University of Pennsylvania. The kids don't know what this is, all the adults do. I had the kids raise their hands if they've ever seen the inside of a toilet, and none of them raised their hand. Essentially, a concussion is a bad flapper valve, where the flapper valve is bad. What happens? The toilet runs and runs and runs. That's what happens in a concussion. Motor pathophysiology, it's a bad reed valve in a 2-stroke. Okay? The motor doesn't run very well if it's a bad reed valve. So, again, on the left-hand side, we're sleeping. We're inactivated. Nothing's flowing in and out, no potassium, no sodium, except if we're having either a good or a bad dream. Normally, the flapper valve on the right-hand side at the bottom opens up, lets in some potassium, lets in some calcium, some sodium, and then when it's done firing that axon, which is a nerve, it shuts. It shuts off. In a concussion, the flapper valve gets back and it stays open. And until the body heals that, it's going to cause symptoms. And we'll get into what some of the symptoms are. And it's this rapid influx of sodium. It's highly variable how quick it heals. Everybody's different. Every symptom is different. And the hardest part is trying to determine when are they ready to go back, because there's a lot of different factors involved. Brianna, you are welcome to chip in at any time. Who's at risk? Males, football. Number 2 is motocross. All right? And we'll get into how they're a little different. In females, cheerleader. That's the same thing. Okay. Next is the female soccer player. Female soccer player has 4 times the incidence of concussion than the male soccer player. Third is motocross, even though there are many participants, female participants are much less. Football helmet versus moto helmet. They're designed differently. Football helmets are designed to take multiple hits. They are lower threshold hits, but they're mobile. Some of the studies, particularly out of the University of Virginia and Virginia Tech does a lot of monitoring. They get a game, some of the athletes will take 200 hits a game. Okay? Now, do they get 200 concussions? No. But it's designed to take multiple hits and then to be used next week. In moto, we have less frequency, but our impacts are larger, much larger. Our helmets are designed to take those large impacts. Depending on the certification organization, their definition of what is adequate can really sometimes be a problem. One of the classifications, which is well respected, but to pass their test, you have to have an extremely rigid outer shell, which doesn't absorb force. So now there are some newer designs out there, and what I tell lay people when they say, what helmet should I buy? I don't say ASRs, I say a modern helmet. Okay? There are many different versions of the modern helmet, whether it's the 6D ODS, whether it's the MIPS, the Fly proprietary helmet, and Bell's got their own set of proprietary helmets as well. A modern helmet is the but we also know motor athletes, when in doubt, they're back on their bike. Okay? And that's why on-site medical care is so important to understand moto and understand moto athletes. Who's at risk? Young athletes. Why? Because the brain is still growing. Okay? It's still developing. That's why teenagers just drive us all crazy. That it's still growing, they're still modifying it, and if they get an injury, that can either stop it or change the direction of it. The most sensitive age is 9 to 12. When do our moto athletes really start getting going? 9 to 12. The age-appropriate risk. Hockey is outlawed checking under a certain age. Soccer is outlawed heading under a certain age. We haven't done too bad with our displacement in combination displacement and age recommendation. Are we immune to it? No. Other risk factors, and besides your organization, I've been here with Road to Recovery on their mental health initiative. There are significant pre-existing mental health disorders that can aggravate it and significantly prolong recovery. So it's important to know your athletes. And I think, but personal history of mood disorders, family history of mood disorders, whether it be mom or dad or grandma, or brothers and sisters, migraine headaches, that just they might not have had them before, but if there's a personal or family history, it's really going to aggravate it. Biggest one is history of prior concussion, okay? And particularly a very recent prior concussion. The delayed symptom onset, they may be on the track and they may get up groggy, and the diagnosis is pretty easy. But it can show up 6 to 8 hours later. They can feel fine. If they race another motor that day, and then they crash. Okay, not on the bike, but crash as they're back to the road development. And there's a whole classification of headache. These are the pre-existing ones, but concussions can also bring these out for a lot of different reasons. Anxiety is the biggest. What happens, doesn't matter what it is, concussion, an ACL, a femur. What does that athlete go through mentally when they're off for that 6 to 8 months? They get depressed, they get anxious, they get angry. They get angry just at the situation. Depression, migraine, psychosis. If they've got significant psychosis and they're on a dirt bike and they get a concussion, it can markedly aggravate. In guys like me, well, memory disorders, but in guys like me, I don't have it yet, but dementia. Okay? In Riverside County, California, there's an old-timers and motocross club. Okay? They're great guys. I do not try to ride them, but it can aggravate them. And then, most importantly, working with the on-track school people, learning disorders and memory disorders in kids that are going to school. California, we have way too many laws and regulations, but in California, it is a mandated not only return to play program after concussion, but a return to learn program after concussion. Support for mental health disorders. And I gave you a handout on this, which is hot off the presses. It came 2 weeks ago. It's a letter to the editor from a PhD psychologist at the University of Washington that addressed essentially the coaches on how to deal and how to help recognize a mental health disorder in the athlete. Okay? And again, if there's a concussion, be really aware to look for it. But you be proactive. You encourage them to verbalize. All of these things you're doing is coaching anyway. A lot of it is basic coaching techniques. Thank them for their courage to come out. And empathy. Say, whether it be, I understand, or I see the pain that you're having, however you want to express it, that will work best for that athlete. Ask them what they need. We are trying to destigmatize the mental health issues. Not make them go away, but not saying that guy's crazy. Right? Okay. And make referrals, and then when they're not competing, and I mentioned this before, make a connection. Stay with their athlete, call them, whatever they're trying to deal with, until they can get back under your wings as a coach. The worst thing for an athlete is to feel they've been abandoned. Younger athletes, prolonged recovery relative head and size of the head versus the body, the bobblehead. Okay. Previous injuries, weaker neck muscles, so in your conditioning, be sure you work on the strength of the neck muscles. Okay. It won't take it away entirely, but it can reduce the severity because they have greater control. And they don't always want to talk to the parents, and sometimes they don't want to talk to the coaches. Okay. Know your athletes, and that's the trick. Athletes compete at all levels. This is my partner, Dr. Alexander, taking 2 kids away at the Monster Cup in Las Vegas. Athletes at risk. One singular risk. It's called the Y chromosome. Okay. You're a guy. I'm a guy. Okay. And we tend to go a little crazy. All right. Such as Bud Light, your fourth tap drill making. I'm sure none of you have ever said that or heard that. How do we evaluate it? It is state law in every state in the country. If an athlete is involved in an athletic event and you suspect a concussion, they must be removed from competition. It's not just medical standard care, it's a law. All right. California goes even further, but I won't get into that. They need to be evaluated by a medical provider, an MD or DO preferably, that is experienced in training in concussion. Okay? I'm not putting the colleagues down, but the guy who's an ER doc and semi-retired and working in a urgent care center is probably not the person you want to see. Okay? And I'm going to give Brianna Millsap a plug here. She's out of fellowship training sports medicine. That's a big part of the fellowship, is learning about concussions, learning how to evaluate, and it's a big part of that practice. Who do I look for? Because my job with a FEL and AMA and AMX sports in concussion is to help the athlete get into somebody qualified wherever they live. We all know that I'll race in Indianapolis on Saturday, fly to Florida, fly to California, go back to Texas. all over. Over 12 years now, we've developed a list. I obtained that list for into it. The American Medical Society for Sports Medicine, amssn.org, has a Find a Doctor section. I use that. I cross-reference it with the impact test that we use as a baseline neurocognitive test to find somebody, because they need to take, for us, they need to take a follow-up impact. And I cross-reference that to find somebody that's qualified where they live. Right? If I can find somebody within 45 minutes of Smithfield, Texas, I can find it. Okay. And when in doubt, if those two don't work, email me. mxdoc951@gmail. Like everybody, 951's our new area. What are you looking for in symptoms? Right? Headache, confusion, dizziness. Dizziness is not a big prognostic sign. Right? That they're going to recover quick. And when I say quick, right, most guidelines in some states that have laws on this, minimum is somewhere around 7 to 8 days. On the professional level, less than, I should say not less, right at 10% of our athletes get back in 1 week. Everybody else, I shouldn't say everybody else, 70% get back within 1 month. The other 30% can take longer. And you have to look at it. But feeling slowed down, fatigue, visual disturbances. Right? Football players say, can they turn the intensity of the stadium lights down? Noise. I don't let the guys go out for opening ceremonies if they've had a concussion in practice. Memory dysfunction. My first line is this lady that's standing over here. I ask them, who is it? If they can't identify their mother, wife, or girlfriend, that's a bad sign. Okay? And that is happening. We call it the look. It's just a vacant stare. Yeah. I'm looking at Mark eye to eye, but someone with concussion is going to be looking at the back of the room. I have a couple of vacant stares in motocross guys, but it's hit by that, so I can't show it. And inappropriate behavior. They laugh when they should be crying. They cry when they should be laughing. And again, dizziness is important. If the athlete starts to have nausea and vomiting or seizures, don't say you have a concussion, you'll be okay. That's a 911. Those are potential signs of a more serious injury, commonly known as brain injuries. Like all doctors, we do a history, we do a physical exam, and there's certain components to it. We may do what is known as a SCAT-5 test. It's a test that's been developed over the years, now on its 5th version. We don't do it all the time because if we've made the diagnosis of concussion, it doesn't matter what the test says, and the test can aggravate the concussion. The diagnosis is all of that. We provide what deficits we see into some simple things, cognitive. What race are you at? Who won last week? Okay. We try to put it in modal terms. How did you do last week? Ocular, the visual fields. There's a very specific exam called VOMS. A little bit more than how many fingers do I have. That's part of it, but there's it's a lot more. It's a lot more than that. Vestibular balance. Okay. From the simple as standing together, hands on the hip, and shut your eyes, and they go like this. So 1 foot in front of the other. It's almost, hopefully none of you have had this, it's like a DUI valve on the side of the road. Okay, it's what they look at. Cervical pain in the back of the head, auditory, either hypersensitivity or loss of hearing. And then headaches, migraines, over anxious or extremely depressed and moody. The risk of continuing to play. All right. Prolonged recovery. An athlete that might get back in 3 weeks if they go out and keep doing it and take another hit. and aggravate the symptoms they already have is going to prolong it, okay, and significantly prolong it. There is a condition called the second impact syndrome. It's rare. I've seen one. I never want to see another one, okay? And it's a concussion that hasn't resolved, and then they take another severe hit. I guess I can say two. Okay. The first one I saw, high school football game. I'm taking care of the inner city Catholic school. We're playing the suburban school where all the doctors live, etc. And kid, son of a doctor, catches the opening kickoff, runs for a touchdown. What do his teammates do? Give him some head slaps. He had a concussion on Wednesday. Second impact syndrome is massive immediate swelling of the brain and brain herniation. I had 3 neurosurgeons in the stands, and he was in surgery within an hour, which never happens. Okay, and he's okay, but I never want to see that again. Okay, and it can happen in moto as well. And again, return to play part of fancy words. Resolution of the pathophysiology can lead to prolonged syndrome. Graded set of symptoms, okay? If you lose consciousness, that's a concussion. 25% of concussions lose consciousness, which means 75 don't. So if they have a what we call an LOC, yes, that's a concussion. Believe what the first people on the track that get to your athlete say. It may be you. Because sometimes they'll start to clear before they get to the medical unit, which kind of confuses issues. But I feel strongly about knowing in the team that you have on the track and believing that. Testing for concussion. Can we see it on CT scan? No. No. I have a warped sense of humor, at least according to my own dog. And you can't. This is why many times we don't send somebody with concussion to the ER. However, when we do our eval, there are other warning signs, and we don't hesitate to send them because of the damage that might be done if we don't send them. Blood biomarkers. Can we do a blood test for concussion? There are 2 blood tests that are out there right now, and I'm sure there are more coming down the pipe. The first one actually was developed by Dr. Reiman, not me, a gentleman at Banner Institute in Arizona, and very smart man. I actually had the opportunity to meet him, but as he says, I'm not the most famous person in the family because my sister married Dale and her Judy. But it's a biomarker, it's a blood test to determine, do you need a CT scan? There's only 2 problems with it. It costs $400, and it takes 3 to 4 hours to do the test. No ER doc in their own right will wait 3 to 4 hours for a blood test if they suspect anything wrong. Right? So it has it's a good idea, but the mechanism of the test hasn't shown. There's a second test developed by this Doug Smith at University of Pennsylvania. It's authorized by the FDA. It's not widely used. There's still a lot of studying that needs to be done. It's a blood test to determine recovery. When is the athlete ready to go back? And that's a tough decision. It's a tough decision for doctors. It's a tough decision for athletic trainers. It's a tough decision for coaches. We err on the side of caution. But if that pans out, that could be a big help as we're trying to get people back, not just on an athletic field, but a work comp type of thing, a construction worker who takes a fall, or somebody drops a board on their head. FIM medical code. All right. This is from 2017. It hasn't been updated. The FIM medical code in 2002 is If you had a head injury and you had neurosurgery, you had to be off your bike for 6 months and then you could get back. Okay? And I'm just going, what? They've updated. Every 3 to 4 years, COVID has messed this up like it has a lot of things. There's a consensus conference held in Europe on concussion. And it's worldwide with multiple sports that not only US and European, but Australia, New Zealand, multiple sports, soccer, Aussie rules, football, rugby, UFC is represented, and it's by the researchers are there as well, and they developed a recommendation. FIM refers directly to that statement. Most physicians refer to it, may not follow it like the Bible, but they use it. Their 2023 is supposed to be the next conference, we'll see. I'm working on an invitation, it's in Geneva, so that. Related to all of us, the NA rulebook. Hopefully there'll be no stones thrown at me. I wear a lot of hats. One of the other hats is on the Medical and Safety Commission of the AMA. When they asked me to do it, they forgot to mention that I was supposed to be chairman. They told me that a month later. So, but anyway, 3 years old concussion policy, and we upped it, and we added one line. The biggest line that we added was to keep it compliant with state law. The head race official, if they suspect a concussion, can remove that athlete from the competition that day until they're evaluated. Just like a high school head referee can make that decision as well as whatever that local medical coverage is. The EMT can make that decision. That's safe. But that's a big difference. And also defined the athlete must see an experience, physician experiencing concussion. And again, the semi-retired ER doc working in urgent care may not be the right person. They may be. They may be, depending on their experience. But it's a stronger statement in the AMA rulebook. So particularly if the head race official says it, and as coaches, you know what's going on. You could say, love to let you ride, but it's in the rule. That's always a good outcome. How do we rehabilitate? And this is where you as coaches can really come in and help. All right? It's a relative rest. We don't do a cocoon therapy anymore, lock them in a dark room. And, we do some other things they don't like, but we don't lock them in the dark room. We avoid potential for re-injury. Drives me crazy. We've disqualified a kid for a concussion, and I see him riding a pit bike. Okay? Football, quarterback got a concussion, first half, he's out, throwing the ball around with his teammate. Uniform was off, and the backup quarterback was throwing as well, and the guy with the concussion got hit in the head with the football because he wasn't wearing a helmet. He was out 6 weeks. Avoidance of excessive visual and audio stimuli, night, lights, noises, video games, cell phones, texting, stuff like that. Okay? What I call flashbang movies. I tell the athlete, go watch a movie your mom wants to watch. Okay? But don't go watch the big violent, crazy stuff going on. They will need short-term, at least short-term, and sometimes long-term modifications of schoolwork. And that's working with the school. Depending on where you're at, some schools are very attuned to that, some schools are not. Depends on the school nurse, depends on the school district. And it's important wherever your local area is. And I'm happy to send the California version of the Return to Learn protocol form that they use. And again, a lot of states have it, some do not. We do balance and vestibular rehabilitation. We do simple things. We do ocular rehabilitation. A friend of mine calls it the pencil push-up. That they hold the pencil and come in and out, and they're rehabbing their eye motion. Okay. Balance, they're doing the flamingo, they're doing some of the other things that we do on an examination that they work out. They use a BOSI ball in the more advanced phases and things like that. But this is where your coaches who are working on not only the writing technique, but their conditioning can really help out because you're watching them. And then a gradual return to activities. For pro motocross and supercross, we do have an aggressive program. All right? They do have, if they pass everything, they have the potential for getting back in one week. Again, 10%. Our protocol, that's the next slide. Oh, okay. I'm getting ahead of myself here. How do you prevent it? Proper equipment, conditioning. Be in shape to ride, don't ride to get in shape. The age-appropriate racing and training, baseline neurocognitive testing, we use on the professional level. There is data out there now that it's useful, but it's not the only thing. You don't hang your hat on it. It's one part of the evaluation process. So if you don't have it, it's not necessarily a big deal, but at the same time, if you have it, it adds to that decision making. Education of writers, coaches, parents, and that's why I'm here. Okay. You can ask my wife, I'll talk to anybody anytime. Particularly the support group, the medics on the track, okay, and all those people that are involved. The AMA officials that are on the professional level are very good about give me a heads up on the radio, check this guy out. I don't think he's right. It helps on the professional level. Their mechanics, their team managers are also very much attuned to this. And to be honest, some of the guys put way too much on social media that we find out. And we call them into the ring. Prompt qualified physician evaluation, athletic and academic modification. And again, gradual return to rise. All right, the one thing, yeah, that's enough for now. Let's open it up to questions. Yes, Jim.
Yeah, so you were talking about the blood test and being able to identify through a blood test if an athlete was recovered from the concussion.
Correct.
Can you explain a little bit about what that is?
Yeah, ironically, the substance they're evaluating is shortened up to the three initials NFL. Okay. A little ironic. That's what they're measuring. The problem with blood tests, there's this thing that's called the blood-brain barrier. So what happens in the brain doesn't necessarily get into the circulating blood. Okay, and what's in the circulating blood may not get to the brain. That's why there really aren't any nutritional supplements to help you recover from the concussion. But that's what they're looking at. There's a couple other substances they're doing, but this NFL neuro, help me, Brianna, okay, I just say NFL. Yeah, but that's what they're looking for. Okay. They're getting more sophisticated for people with chronic head injuries and having problems later. But now, they're not cheap, they're very sophisticated. They're measuring the tau protein, it's present in dementia and in CTE as well. Any other questions I can answer? Brianna, any thoughts to add to it?
So today I evaluated a girl who had had a lot of previous, microphones, who had had a lot of previous concussions, and she went to her primary care, and they were trying to treat her with medicine, all kinds of things for these post-concussive symptoms. She had never gone to a sports medicine or she had been evaluated and treated for these concussions. And some of this stuff is easy. You just send them to vestibular therapy or ocular therapy, and she'd probably get a lot better instead of trying all these medicines that makes her worse off the track. Same thing with guides. So I just make sure that they're evaluated by the right person. It really does make a difference. And these therapies, the vestibular and the ocular, make such a difference. I know we're using it in TF extensively, and it's doing really well. The second thing I want to mention is the research shows that right after concussion, you want to load them with glucose because it helps the brain heal and everything. And that's something that you guys can do. So they hit their head, you suspect it, immediately give them like those glucose, packets or whatever. So make sure you feed them because the quicker you feed them, the better they get. It's just something I want to mention.
I told you I was going to put you to work. No, absolutely. And, in our sport, it's not only the glucose, we get them rehydrated as well. Any other questions or comments from you? Yes.
The helmet discussion about motorcycle helmets are one-hit wonders. Is there something you can recommend that we look for inside of the helmet when you think, oh god, that thing needs to go in the garbage?
Yeah, the question is, on motorcycle helmets, what do you look for to try to determine, is it damaged or not? Okay, and when does it need to go to the trash? Couple things. I do look at the outside for scratches, etc. If you look at the visor, if the visor's been ripped off, particularly if it's one that's still screwed in, you probably should get rid of it. You look inside, you remove the liner inside and look at the styrofoam inside. If there is any indentation, it should be replaced. Now, several companies are now starting to refurbish helmets, but the only part they refurbish is the inner EPS styrofoam and their whatever they're using for their modern design. If the outside of the helmet is damaged, they're not going to refurbish it for it. So the quick answer is when in doubt, to throw it out. The best answer is look inside. Anybody that comes into our mobile medical unit that we're evaluating for concussion, we take pictures of the helmet, and the helmet manufacturers then look at the helmet because they want to analyze it. That works fine for the factory guys. The privateers don't want to let loose because of their budget. Don't want to let loose in the helmet. We've made arrangements with 6 different helmet manufacturers that at the professional level, our privateer will get his helmet replaced.
Thank you.
Yep.
So my biggest takeaway is if the EPS did it, it's got to go.
It's got to go. And if it's not a company that even offers refurbished, it's got to go.
It's not working.
Anything. I want to thank you all for allowing me to be here. And again, I apologize for being overdressed for the red lens, but I think you understand. Thank you much.